Welcome, gang. Hey, in the development of this course, I almost forgot the immunoproliferative disorders, so we don't want to forget those. This is a short unit, but I do want to talk about the immunoproliferative disorders. I'm going to be talking today about monoclonal gammopathies and polyclonal gammopathies and multiple myeloma and light chain disease and a few things like that. So stay tuned. Let's go ahead and start by defining a plasma cell dyscrasia. Dyscrasia basically just means disease. So when a plasma cell is greatly increased and completely infiltrate the bone marrow, this is called a plasma cell dyscrasia. Some conditions associated with plasma cell dyscrasias are things like multiple myeloma and Waldenstrom's macroglobulinemia. Multiple myeloma is a monoclonal gammopathy. A monoclonal gammopathy is characterized by the production of monoclonal immunoglobulins and are associated with suppressed, uninvolved immunoglobulins and dysfunctional T cell responses. Multiple myeloma is the prototypical monoclonal gammopathy. And then we're also going to talk later about the polyclonal gammopathies, and that is a common protein abnormality. It is defined as an increase in more than one immunoglobulin and involves several clones of plasma cells. In contrast to monoclonal gammopathies, a polyclonal protein consists of one or more heavy chain classes and both light chain types. Multiple myeloma is a plasma cell neoplasm characterized by the accumulation of malignant plasma cells within the bone marrow, microinvolvement, monoclonal proteins in the blood or urine, and associated organ dysfunction. Plasma cell tumors form in the bone marrow, and the bone marrow cells are actually replaced with plasma cells. A normal bone marrow has less than 1% plasma cells. In multiple myeloma, plasma cells can be about 90% in the bone marrow, and these plasma cells can be malignant. This is also known as plasma cell myeloma. Tumors erode the surrounding bone, and fatalities usually occur as the result of renal failure or sepsis, generally 1 to 3 years after diagnosis of multiple myeloma. There is an unknown cause for multiple myeloma, but some people have speculated that it's due to radiation exposure or some sort of viral pathogen. Bence-Jones proteins are proteins seen in the urine of patients with monoclonal gammopathies. It is especially seen in people that have multiple myeloma. You may recall also that people with multiple myeloma have rouleau on their RBC on the white cell and RBC differential. But Bence-Jones proteins are a type of light chain protein that can be found in the urine of people that have multiple myeloma. I'm sure you've talked about this in a urinalysis class. Other monoclonal gammopathies would be Waldenstrom's macroglobulinemia and cold agglutinin disease. In Waldenstrom's macroglobulinemia, this is a B-cell disorder. It's a malignant B-cell disorder characterized by many plasma cells in the bone marrow. Here, IgM is greatly increased. The cause of Waldenstrom's macroglobulinemia is unknown, but it is possibly genetic or a genetic mutation. People that have Waldenstrom's macroglobulinemia have about a 3-year life expectancy and are diagnosed with organ failure due to hemorrhage in the liver and spleen. Now, in Waldenstrom's macroglobulinemia, there are many plasma cells that produce high amounts of IgM. People that have this disorder have very viscous blood because there's too much and too large of IgM complexes that stay in the blood plasma. It fails to move to the interstitial fluids, and the blood is very viscous, and it causes high blood pressure and blindness. Then we have a second monoclonal gammopathy called cold agglutinin disease. This is basically a microobstruction of the circulatory system. This is an IgM disease. It is sometimes considered a hemolytic anemia associated with cold reacting autoantibodies. Now, both monoclonal gammopathies, including also multiple myeloma, and these two here, are treated with steroids and chemotherapy. Other monoclonal disorders would be light chain diseases and heavy chain diseases. In light chain disease, monoclonal proteins are composed of the light chain portion of the immunoglobulin. There are many light chain fragments produced, and the light chain diseases represent about 10 to 15% of all monoclonal gammopathies. The heavy chain diseases are when monoclonal proteins are composed of the heavy chain portion of the immunoglobulin. There's a large amount of heavy chain fragments produced in this type of disease, and some symptoms of heavy chain disease would be things like weakness, fever, increased bacterial infections, an enlarged spleen, an enlarged liver, and anemias. Polyclonal gammopathies are common protein abnormalities. They are defined as an increase in more than one immunoglobulin, and it involves several clones of plasma cells. So, polyclonal gammopathies that I'm going to mention today would be things like chronic liver disease, such as hepatitis B virus, chronic infections, or autoimmune diseases such as rheumatoid arthritis. These can all cause polyclonal gammopathies. Usually it results as a secondary heavy or light chain disease. They're not as common as the monoclonal gammopathies. Labs detect monoclonal gammopathies and polyclonal gammopathies with protein electrophoresis. Immunoelectrophoresis is the most commonly used type of test to diagnose the monoclonal and polyclonal gammopathies. Serum proteins like antibodies all have different charges, and they can be separated in distinct bands via electrophoresis. Immunoglobulin deficiencies can be diagnosed using electrophoresis, and polyclonal or monoclonal gammopathies show gamma globulin in the blood. So a normal electrophoretic pattern, I'm going to show you in the next slide as soon as I discuss the principle of electrophoresis. So the patient's serum will be separated into 5 fractions based on the rate of migration of these components in an electric field. Immunodiffusion is used to identify the size and position of precipitin bands. Each line represents one protein. So let's go ahead and take a look at the next slide. This rudimentary drawing is a pretty good example of what a normal electrophoretic pattern looks like, where you have a large band of albumin, and then you have kind of these small humps of alpha 1 and alpha 2 globulins, and then we have the beta globulins, and finally the gamma globulins. So if you had a patient that had a monoclonal gammopathy or an immunodeficiency, you would notice that that gamma globulin band would be flat. Okay. Now there are several types of proteins that can be measurable in serum, including things like albumin, the alpha 1 proteins, which would be things like alpha 1 antitrypsin, that's seen in inflammation. Our alpha 2 proteins would be things like complement C4, and that's going to be elevated in inflammation. Our beta globulins, such as complement 3 component, and then finally our gamma globulins, where all of our immunoglobulin classes are found. They're found in that gamma globulin band clear over on the right. Also CRP is found in the gamma globulin band. So that's it for the polyclonal gammopathies and the monoclonal gammopathies.